Good morning. I want to thank the meeting organizers for inviting me to discuss three important abstracts under the theme Novel HER2 Positive Agents and Strategies. HER2 amplified tumors are highly addicted to HER2 signaling. Agents that block HER2 and its downstream signaling pathways are highly effective at killing this distinct tumor subtype. These agents include HER2 targeting monoclonal antibodies, HER2 targeting antibody drug conjugates, and HER family tyrosine kinase inhibitors, both reversible and irreversible. We now have 8 HER2 targeted therapies approved for the treatment of HER2 positive breast cancer. 3 of these agents, margetuximab, tucatinib, and trastuzumab deruxtecan, were approved in the last 2 years. Numerous additional agents are in various phases of clinical development as shown here. Today, I will be discussing 3 abstracts focusing on 3 of these agents. First, the novel ADC ARX788. Second, the irreversible HER-TKI pyrotinib. And third, the CDK4/6 inhibitor palbociclib in combination with trastuzumab. Here are the 3 abstracts I'll be presenting this morning. The first abstract, abstract 221, safety and anti-tumor activity of ARX788 in the ACE-Breast01 trial presented by Dr. Zhang and colleagues. ARX788 is a novel HER2 targeting ADC consisting of an anti-HER2 monoclonal antibody linked to a potent payload AS269, which is a non-cell permeable tubulin inhibitor. ARX788 is a unique ADC because it utilizes novel technology to enable site-specific payload conjugation. This results in a highly stable compound with a drug-to-antibody ratio of 2 and minimal premature payload detachment. This is supported by PK studies previously presented showing very low systemic exposure of the payload. ACE-Breast01 is a phase 1 trial in HER2-positive metastatic breast cancer. 69 patients were enrolled in China, and the dose was escalated to 1.5 mg/kg with no DLTs seen at that dose level. Dr. Zhang and colleagues at this meeting update the efficacy results in the 29 patients enrolled at the 1.5 mg/kg cohort. All of these patients had received prior trastuzumab, and the confirmed overall response rate was 66%. Median PFS was 17 months, and you can see in the spider plot that the responses were rapid, deep, and durable. If you look at the table breaking down prior anti-HER2 therapy, you can see that most of these patients received at least one additional anti-HER2 therapy in addition to trastuzumab. The majority of patients received HER-TKI, and in that group, the overall response rate was similarly 65%. Very few, however, received TDM1 or other HER2 ADC. However, the high response rates were seen in all of the anti-HER2 therapy subgroups, even if many of them had very small numbers. The ARX788 toxicity profile has been previously reported, and as the PK studies could predict, drug-related high-grade AEs were very low. Only 3% of patients discontinued treatment due to toxicity. Specifically, there were no grade 3 or 4 events of nausea, vomiting, or diarrhea, only 1% grade 3 or 4 neutropenia, and there was no neuropathy of any grade, which is remarkable given that the payload is a tubulin inhibitor. Like other ADCs, ocular and pulmonary toxicities were seen. 33% of patients developed pneumonitis or ILD. The majority of these were low grade, only 4% were grade 3 or 4, and importantly, there were no grade 5 events. Ocular toxicity was common, with 46% of patients reporting keratopathy, approximately 20% blurred vision, and 20% dry eyes. And these also were mainly low grade. Despite having a non-permeable payload and a DAR of 2, which suggests little bystander effect, ARX788 shows promising early efficacy signals. The overall response rate was 66% in a post-trastuzumab, post-HER-TKI setting. This is similar to what has been reported in early reports with other ADCs, including trastuzumab deruxtecan. However, in the ACE-Breast01 study, very few had prior pertuzumab and TDM1. ARX788 is a novel HER2 targeted ADC with little premature payload release. And this may explain why there were low rates of high-grade toxicity and toxicity-related discontinuation. High rates of low-grade pulmonary and ocular toxicity were also seen, although importantly, no grade 5 events were reported. Mitigation strategies are being developed and implemented in ongoing larger studies, and close follow-up is necessary. We await the results of the ACE-Breast03 trial, which is a phase 2 single-arm study in a more heavily pretreated population post-TDM1, TDXT, and tucatinib. The second abstract 1201, overall survival results from the phase 3 Phoenix trial of piratinib plus capecitabine, presented by Dr. Jiang and colleagues. Piratinib is an irreversible pan-HER-TKI targeting EGFR, HER2, and HER4. The Phoenix trial is a phase 3 randomized trial conducted in China. Enrollment started in July of 2016, and investigators at that time wished to test piratinib in a real-world setting. At that time, trastuzumab and lapatinib were not universally accessible, and pertuzumab and TDM1 were not approved. Thus, HER2-positive metastatic breast cancer patients previously treated with trastuzumab and who had received up to 2 lines of chemotherapy in the advanced setting were randomized in a 2-to-1 fashion to piratinib or placebo in combination with capecitabine. Patients in the placebo arm could cross over to piratinib monotherapy at the time of progression. The interim analysis with a median follow-up of 8.6 months was previously reported. 274 patients were enrolled, and 30 to 40% had not received trastuzumab in the metastatic setting. PFS was significantly prolonged with the addition of piratinib, 11.1 months versus 4.1 months. Of the 71 patients that crossed over to piratinib monotherapy, the overall response rate was 38% with a PFS of 5.5 months, demonstrating significant monotherapy activity of piratinib in this relatively HER2 treatment naive population. Grade 3 or higher rates of diarrhea was similar to what has been shown previously with other irreversible pan-HER-TKIs, 30% for the combination of piratinib and capecitabine, and 22% with piratinib monotherapy. The overall survival results are shown here with a median follow-up of 42 months. Overall survival was numerically longer, but not statistically different with the addition of piratinib to capecitabine. The post-progression subsequent therapy in this trial was limited. 30 to 40% of patients did not receive subsequent anti-cancer therapy. The authors conducted a number of subset analyses, including one in patients with baseline brain metastases. 11% had baseline brain metastases, and improvement in PFS was seen in this subset, similar to what was seen in the overall trial population. More data regarding the CNS activity of piratinib is needed, but I want to highlight one trial, the Permeate study, which was presented at ASCO this year. This study enrolled 78 patients with measurable CNS disease into 2 cohorts based on prior CNS radiation. Both cohorts were treated with piratinib and capecitabine, and authors reported impressive CNS overall response rates as well as CNS PFS. These results were very encouraging. So where does piratinib fit? The Phoenix trial demonstrates that piratinib is an active agent with a similar toxicity profile to other irreversible pan-HER-TKIs such as neratinib. It is difficult to interpret piratinib efficacy in the broader context due to a non-standard control arm, limited prior HER2 therapy, limited subsequent therapy, and almost all placebo patients crossing over to piratinib. We know from the Phoebe trial that the combination of piratinib and capecitabine resulted in superior PFS compared to lapatinib and capecitabine. The overall survival results from Phoebe will be presented at the general session 3 today by Dr. Xu immediately following this session. Most of the world cannot access most of the proven highly effective HER2 targeted agents, including tucatinib and neratinib. Active drugs like piratinib are important to develop and study in the real-world setting in order to improve access and outcomes globally. Where TKIs fit depends not only on toxicity profile and CNS activity, but also cost and accessibility. The final abstract 1204, palbociclib and trastuzumab, final results from cohort A and B from the Patricia trial, presented by Dr. Surelos and colleagues. CDK4/6 inhibitors are well established in the treatment of hormone receptor positive HER2 negative breast cancer. There is mounting rationale and evidence that CDK4/6 inhibitors may also play a role in HER2 positive breast cancer. In preclinical models, trastuzumab and abemaciclib are synergistic and can resensitize resistant HER2 positive tumors. The MONARCH-HER trial showed that the triplet of abemaciclib, trastuzumab, and fulvestrant resulted in improved overall response rates, as well as a significant 2.6-month improvement in PFS compared to trastuzumab-containing chemotherapy. This suggests that a subset of tumors may benefit more from a hormone approach with CDK4/6 inhibition rather than chemotherapy. The Patricia study is a phase 2 open label study that enrolled HER2 positive patients into two cohorts, ER negative and ER positive. The ER negative HER2 positive patients enrolled into cohort A and were treated with palbociclib and trastuzumab. ER positive HER2 positive patients were randomized into cohort B to receive either palbociclib trastuzumab or palbociclib trastuzumab and letrozole. The primary endpoint was PFS rate at 6 months. The final PFS and OS results by treatment cohort are shown here. 71 patients were enrolled into the three cohorts. Cohort A, which was the hormone receptor negative cohort treated with trastuzumab palbociclib, did not move on to stage 2, given the relatively low 6-month PFS rate and only 1 out of 15 patients having a response. The cohort B and cohort B1 and cohort B2 did move on to stage 2. The PFS was similar and not affected by whether patients received letrozole with the trastuzumab and palbociclib. Not unexpected, the overall survival was longer in the ER positive cohort B patients as compared to the ER negative cohort A patients. PFS and OS by PAM50 subtype was a pre-planned secondary endpoint. Over 80% of tumor samples underwent PAM50 subtyping, and 39% were found to be luminal A or B. When PFS was assessed by intrinsic subtype, patients with luminal subtype had a significantly longer PFS than patients with non-luminal subtype, 10.6 versus 4.2 months, which was statistically significant. Overall survival was also longer in the luminal subtype compared to non-luminal. However, this was not statistically significant, likely due to small numbers. Due to these findings, cohort A and B were closed early, and cohort C was open and is currently accruing. Cohort C is accruing hormone receptor positive, HER2 positive metastatic breast cancer patients with PAM50 luminal subtype. Patients are being randomized 1-to-1 to palbociclib, trastuzumab, and endocrine therapy versus physician's treatment choice of chemotherapy. Patients randomized to the physician's treatment choice of chemotherapy can undergo a second randomization at the time of progression. So what can we learn from Patricia? Patricia is one of the first metastatic HER2 positive trials to characterize the molecular diversity of HER2 positive breast cancer through intrinsic subtyping and demonstrate its prognostic value in the metastatic setting. However, whether luminal subtype can predict palbociclib benefit in HER2 positive disease cannot be addressed in cohorts A and B of the Patricia trial. We await the results from the ongoing cohort C of Patricia trial, and I think this trial will help answer this question. Interestingly, in HER2 negative disease, an exploratory analysis of 3 Mona Lisa studies conducted by Dr. Pratt and colleagues showed benefit of ribociclib in patients with both luminal and HER2 enriched subtypes. This raises the question of whether the benefit of CDK4/6 inhibitors as determined by intrinsic subtype might be different for HER2 positive and HER2 negative cancers. And finally, what about the non-luminal subtype? Can PAM50 serve a potential role in identifying HER2 positive patients with particularly poor prognosis for whom we must prioritize novel approaches. And here are my final thoughts. We are entering a new era in HER2 positive disease where we will have an increasing number of great options. Treatment options will have increasing PFS, but some will also have risk of developing rare but serious toxicity, such as ILD. Methods to further risk stratify HER2 positive patients are needed in order to tailor the therapeutic approach and inform the sequencing of the many great treatment options. Sequencing will likely not be one size fits all and will likely be influenced by many factors, including individual tumor biology, toxicity profiles, CNS effects, and of course, access. Thank you so much for your attention.